We are going to make an overview of what we call contact X-ray brachytherapy using the Papillon system and 50 kV X-rays. As you see here, I have been working for 30 years with contact therapy in Lyon, and since 2001, I've been working 20 years in Nice with the same kind of technique. I am the medical advisor of the Ariane Medical System company, and this is in Alpheton, where the Papillon 50 and now the Papillon Plus is designed. Short after the discovery of X-rays in 95, in 1902, the first skin cancer of the nose cured with 50 kV X-rays in Stockholm. But the real start of contact therapy was Professor Shaul in Germany, Berlin, with a Siemens machine where he was able to treat large skin cancer with great success. Finally, it was in the 1960s that Papillon was able to use this machine to treat rectal cancer. At that time, it was a Philips machine. The patient was in the knee chest position. We introduced the rectal applicator, and inside we introduced the X-ray tube. And you see that this is a 3 centimeter X-ray tube. Tumor 60 gray in 2 minutes. 2 weeks later, shrinkage of the tumor, another 30 gray, 20 gray, and 10 grays, and local control. Papillon was able to publish more than 200 patients with a 90% success for rectal carcinoma, mostly T1 polypoid tumors. My main merit was to make a randomized trial to compare in operable patient with T2, T3 tumor, pre-op radiotherapy alone with pre-op and a boost with contact therapy. And you see that the rate of clinical complete response moved from 2% to 30%, significant when you use 90-degree boost in 3 fractions with contact. And the sphincter preservation was 44 to 76%, also highly significant. 10 years later, we updated the data, and there was still a difference between contact and no contact for sphincter preservation, and this made possible the validation by the Haute Autorité de Santé, which is like the NICE in UK, of contact therapy to treat rectal cancer in T1, T2, and T3 tumors. This is an example of a tumor close to the anal canal, clinical complete response after contact therapy and external beam, local excision, tumor sterilized, and 14 years later, organ preservation with good bowel function. But when I came to Nice in 2001, the applicator was not anymore used. And they say you have to stop the Philips machine. And I was a chance to meet Mr. Keith Penswick, who was able to design a new X-ray tube that we called Papillon 50. And it was a renaissance of contact therapy in rectal cancer. The system is exactly the same. You put the applicator in the knee chest position. You can locate very accurately the tumor. When everything is fixed, you introduce the X-ray tube with the micronodes, and you give 30 gray in 2 minutes into a very small volume of 5 cc's. So as you see, contact therapy is safe, efficient, simple, but of course, it needs some clinical experience. With the Monte Carlo code, you can make a dose distribution, and you can see that you irradiate a very small volume to a high dose in a short time, and this is the main merit of this technique, which is completely safe due to this rapid fall-off of the dose. Some example, very typical, a T3B seen on the sonography, a T3A on the MRI. Both tumors look more or less the same, and after contact therapy and chemoradiotherapy, local control, good bowel preservation, good bowel function. we were able to publish a paper called Plan Organ Preservation, because when we treat T2, T3 less than 5 centimeter, mostly polypoid, we can be quite sure that at the end of the treatment, combining chemoradiotherapy and contact therapy, we will have clinical complete response, local control, organ preservation, and good bowel function. And if you start with contact therapy, it is better than if you start with chemoradiotherapy. You can see here that when you start with contact therapy, you have 88% of clinical complete response on week 14, 3 months after the start of treatment, and only 32% if you start with external beam therapy and give contact therapy later after the external beam. With the typical case, you see in 2017, a T2 tumors, 2.5 centimeter in diameter, 30 gray. 2 weeks later, no more tumor or nearly more tumor, small ulceration, another 30 gray, but on a smaller applicator of 2.5 centimeter, and 3 weeks later, no more tumor. So you have complete response, and at that time, you give the CAP 50, week 0, week 2 contact, week 4 contact, then CAP 50, and you move from a T2 and 0 to TRG1, no more tumor. And this is with more than 3 years follow-up. And on this slide, made by an Apple to physicists from Denmark and UK, you see that when you give the boost with contact therapy, you achieve much better local control, clearly 90%, than with other treatment applicable to rectal cancer. I was lucky in 1992 to work with Professor Sunmin, who went back to Clatterbridge, Liverpool, who set up a very nice papillon suite where he have treated more than 1,000 rectal cancer. It's the largest experience. There is 4 machines in UK and more than 600 patients treated in the world. And this is a medal that the British Medical Award that the British team from Liverpool, from Hull, from Guildford, and from Nottingham received for their beautiful result in rectal cancer. But the standard treatment for rectal cancer for organ preservation is abergamma with chemoradiotherapy alone. So the question is, chemorad alone or chemorad plus a papillon boost? With chemorad alone, you have CCR 45, local relapse 30%. When you add the boost with contact therapy, well, you move from 45 to 85 and only 15%. This is what is published, but to demonstrate it is true, we have to make a randomized trial, and this is the aim of the OPERA trial, a phase 3 randomized trial, international. We include T2, T3AB less than 5, operable patient, low mid-rectum. Standard is abergamma, 45 and 9 gray external beam. Experimental, the same chemorad 45, but the boost 90 gray. On week 14, after start of treatment, we evaluate the response, partial response TME, clinical complete response, watch and wait. Organ preservation at 3 years, we want to move to 50 to 80%. The trial is just finished, and the IDMC said you should stop the trial because your results are very promising. So far, it is completely under embargo, but we are optimistic that this trial will demonstrate that contact therapy for organ preservation will become the standard treatment. So contact therapy in rectal cancer is good for organ preservation in selected T2 and early T3 tumors. It can also be used after local excision when you find pejorative information on the pathological report, and at that time you give adjuvant contact therapy plus or minus chemoradiotherapy. The main advantage of contact therapy probably is rectal cancer, but it can be used and more frequently for skin cancer, which is a very frequent disease. You can see here one of my colleagues treating a skin cancer of the nose with the Papillon 50. He gave 7 gray in 10 seconds. Can treat eyelids, and this is a very specific, good indication of contact therapy. Big tumors, very difficult to treat by surgery of irradiation. You give contact therapy, very well localized, and you have local control, no toxicity. Another tumor, same kind of good. This is very easy to control with 6 courses of contact therapy over 4 weeks. Dr. Barbet in Lyon, I was working with him for many years, has been treating more than 1,000 cases of skin cancer, always with good result. And you see here, it is very difficult to have no sequelae, and with contact therapy, the cosmetic result is absolutely perfect. Most of the time, 42 gray in 6 fractions, 4 weeks, or in elderly patients, 60 gray in 3 fractions over 3 weeks. That was my first publication in 1971 with Papillon. We are treating sclerocorneal limbus tumor that you can see here with 6 fractions of contact therapy and local control and no toxicity on the eye or the lens. But now we are entering a new period for contact therapy, which is contact therapy intra-op radiotherapy for breast cancer. It was initiated with the intrabeam machine from Carl Zeiss, and they have treated more than 3,000 patients with excellent results. They make the lumpectomy and then they introduce the X-ray tube inside an applicator, and they give 20 gray in 30 minutes and no other irradiation. And the local relapse rate is less than 3%. When we saw this with the Papillon 15, it was not possible because the angle of irradiation was only 45 degrees. So Mr. Spanswick was able to design a new X-ray generator with a new micronode able to irradiate like a spherical irradiation isotropic. And we call it the Papillon Plus machine. It was what I call now the magic stick. And this is the X-ray tube. This is the monitor, the workstation. You do the lumpectomy, you remove the tumor, you introduce the applicator, then you make a pulse, you can use the GAF chromic for dose measurement. Inside, everything sterile, you introduce the applicator. Everything is covered sterile. You leave the operating room, and in 1 minute, you give 20 gray to the tumor. Then you enter the operating room and you finish the operation. You remove the dosimeter, no irradiation on the skin, but everything is black. It is GAF chromic film because they receive a high dose into the lumpectomy cavity. So with the intrabeam, you have excellent result, but it takes 30 minutes to give 20 gray. With the Papillon Plus, you do exactly the same thing, but you give the 20 gray in 1 minute, which is obviously a large advantage. With the team in Nice who has been doing this first in the lifetime IORT in 1 minute for breast IORT. They have the surgeon, another surgeon, the radiation oncologist, all the team working. 26 patients have been treated. Results will be published soon, but we can say that over these 26 patients, all the results were no toxicity and so far no local relapse. So as you see, of course, radiotherapy is mainly the field of linear accelerator, but probably something like 5% of the patients treated with radiotherapy can benefit from contact therapy, either for skin, for rectum, for breast IORT, for eyelid, for any kind of IRT or intravaginal irradiation. But of course, all these tumors must be accessible. This is a very important point to use this contact therapy. And this is the last slide to show, in summary, what we can achieve in terms of local treatment and conservative treatment. As you understand, contact therapy is very good for early rectal tumor, but also for breast IORT. And this is a patient I have treated in 2013. And she had a local rectal tumor, T3N1, and a small T1 in the breast. And after contact therapy, she was controlled. She had a conservative treatment. And this year, in January, we were able to celebrate 100 years of life with conservative treatment of the rectum and of the breast, which is what we are aiming with conservative treatment and contact therapy. So remind that radiotherapy is a conservative treatment, cost-effective, curative, and contact therapy is playing a very important role and will develop in the near future thanks to this papillon system. Moi, je m'amasse comme le promène, mais si vous voulez enlever le vôtre, là, vous pouvez l'enlever. Hein.
Oh, c'est bon.
Je ne suis pas très attaché au masque, pour tout vous dire.